Good morning. I would like to thank the Medical Society for providing a venue to express my project idea and progress made thus far. The title of my project is Efficacy of a Substance Abuse Screening Tool in the Emergency Department. Substance abuse is crippling our society. Did that move? There we go. Substance abuse is crippling our society. $740 billion. That is what is lost every year due to crime, lost work productivity, and healthcare from alcohol, tobacco, and illicit drug abuse. Per initial CDC data from 2019, 71,000 people died from drug overdose deaths. In 2018, an estimated 95,000 deaths could be attributed to alcohol. And per NIDA and SAMHSA, 480,000 deaths each year can be attributed to tobacco use. That's more than 500,000 people dying every year due to tobacco, alcohol, and drug use. As healthcare providers, our goal is to maintain and promote health. But how do we encourage change? Many patients are not forthcoming with their habits, despite knowing these habits are deleterious to their health, either due to shame or complacency. Can a single interaction encourage a patient to take the first steps towards quitting? Can screening be a transformative moment to the patient? This is why recognition of use is key, and screening is so important. Brief counseling can change alcohol and tobacco habits in the primary care setting, but this has mixed results in the emergency department setting for effectiveness in regards to screening and counseling. This may be due to the lack of follow-up in the emergency department versus when you repeatedly go back and you're supposed to follow your primary care doctor, you'll get repeat prompting. As an emergency department physician, I see the short and long-term consequences of substance abuse. Many patients in the emergency department do not have health care providers, and the emergency department is the only place where they'll have access to referral for addiction treatment. My project will evaluate the efficacy of a substance abuse screening tool in the emergency department. More specifically, will patients who screen positive for substance abuse in the emergency department follow up in an outpatient setting if provided resources? My primary aim is to see if patients benefit from screening, and if they are positive, we'll refer them to outpatient resources. If this is seen as efficacious, I would like to incorporate this screening into triage or provider workflow. Our primary study population was a convenient sample of adult emergency department patients over a screening period of 2 weeks. Patients will not be screened if they are presenting with altered mental status, they have a history of dementia, or acutely intoxicated, as they cannot verbally consent. An interviewer will administer TAPS 1, and if they're positive on TAPS 1, they'll then go through the brief assessment, which is TAPS 2. To those screening positive on TAPS 2, they'll be offered outpatient resources. We will then follow up with patients in 2 weeks by telephone or email survey to see if they contacted one of those resources. So TAPS tool, that stands for the Tobacco, Alcohol, and Prescription Medication and Other Substance Use. This was originally developed and validated in adult primary care patients. The first stage, which is TAPS 1, has 4 items and asks about use over 12 months for 4 substance categories. The second part, which is called TAPS 2, is a brief assessment, and this further delineates frequency and type of illicit drugs over the past 3 months. It's supposed to take a total of 5 minutes, and TAPS 1 should only take 1 minute. I'm not going to read to you all 5 questions, but it's actually technically 4 questions because question 2 is for males and question 3 is for females, and it's regards to binge drinking. Again, this assesses use for over 12 months, and if you answer anything other than never, that is considered positive, and then you'll move on to TAPS 2. So this is TAPS 2, and it is a little bit more detailed. It consists of 9 questions, and it delineates specifically which illicit substance a patient uses and more, and in the frequency over the past 3 months, and also looks at habits that are considered problem use. A little more about the background in TAPS tool. The first screening part, TAPS 1, was adapted from the NIDA Quick Screen. And the brief assessment part, TAPS 2, is actually derived from what's called the Modified Assist Lite, which ASSIST stands for Alcohol, Smoking, and Substance Involvement Screening Test. During validation studies for the original TAP screening tool, they used what's called the Modified World Mental Health composite international diagnostic interview as a gold standard. This is actually used in addiction and psychiatric medicine and takes much longer, but it bases substance use on the DSM-5 classifications for substance use disorders. The definition of a substance use disorder was based on standard diagnostic threshold of meeting 2 or more DSM criteria on a CIDI. On the original validation studies, they did follow-up on oral fluid testing with patients, and they sent it off for illicit substances, but they did not check for alcohol and tobacco. So what's nice about this scoring system is that it's much more simplified than the Systolite. It's essentially, if you score 0, that means no use in the past 3 months. And if you score 1, that is for problem use. And 2+ is for higher risk use and is more consistent with a substance use disorder per DSM-5. What is also useful about this tool is that it can be self-administered or interviewer administered, so it can fit seamlessly into clinical workflow. A cutoff of 2+ was used for DSM-5 criteria for substance use disorder, and this was found to be greater than 70% sensitive for tobacco, ethanol, and marijuana abuse, with a specificity no lower than 85%. A cutoff of 1+ for any illicit drug use was used, and that's 82% sensitivity for illicit drug or prescription drug abuse. So my study was approved by the IRB as exempt status, and we are currently screening patients. We're going to look at the number of total patients screened, and then I'd like to look at the number positive and separate out tobacco, alcohol, illicit, and prescription drug use. We'll then look at the number of email and phone surveys sent and the number that have replied, and then we'll look at the number who contacted addiction resources. As with any survey study, I expect there will be an issue with follow-up. Also, I am concerned about comprehension of the screening tool. TAPS-2 is a little bit more tedious, and I worry about the literacy level of my patient population, and I do have a little bit of concerns about miscomprehension. Unfortunately, the COVID pandemic threw a wrench into all my plans in regards to availability of services and IRB backlog. Potential future ideas for studies would be looking at how easily self-administration in the emergency department is, because I find reading the initial studies, they saw an increase in alcohol reporting on the self-administered test. They also found in a validation study of TAPS-1 that patients disclosed prescription drug misuse 50% more in the self-administered screens compared to interviewer-administered screens. The MyTAPS is actually an electronic form of the self-administration screen, and that can actually be found on the NIDA website. Also, TAPS-1 only takes about a minute, and there was a validation study looking at the initial data from 2017, and they found that TAPS-1 was effective as well. In conclusion, if this appears to be efficacious, I'd like to streamline screening to triage or provider workflow so that addiction resources can be incorporated easily into discharge planning. That concludes my presentation. Thank you for your time and attention. Do you have any questions?
Thank you so much, Jennifer. That's a great presentation and such an important topic and a challenging one for sure. I'm going to take the first question, and I'll look to see if there are others. It seems like this is an opportunity for essentially automating this through electronic means, whereby patients could self-administer the TAPS-1 and then the TAPS-2, if the TAPS-1 is positive, on a tablet or some sort of a computer, that could be uploaded into their emergency department record, and anyone who tests positive could automatically be given the resources, perhaps in an after visit, like discharge packet. Is that something that is realistic to be done? And how do you think that might work?
So I think that if the way our emergency department is set up, our triage area is actually a closed off area. So you may have 2 or 3 patients kind of work through an area, and that would be an opportunity maybe to provide like an iPad and have them go through their information. And while they're sitting waiting for the triage nurse, Unfortunately, due to COVID, we have quite a bit of wait times. Or we could have like a kiosk out in the waiting room. I don't think we could just simply give iPads to patients sitting in the waiting room because I'm not sure if we would have any iPads left. But I think this would be beneficial. And also it would maybe help the patients feel like they're engaged in what's going on and not feel like they're being forgotten about while they're waiting in the waiting room. And they could actually maybe go through some other stuff, other screening material as well, like their past medical history and updating their meds, and as well as screening. So it gets the patient more involved. I think it's a great idea. It's just about how to, right now, keeping everything clean and kind of getting those devices in place in the emergency department.
So you have a comment and a question. The comment from Dr. Reeder was there should also be a good mechanism to communicate the results of the screening back to the primary care physician where the patient has one. And then a question that you got from Dr. Holly Viola was, how many patients have you been able to screen thus far?
So I've only done about probably a total of 3 days of screening. I did not realize how the volume of patients is going to have, and trying to work this around my work schedule and IRB requirements is been I found to be cumbersome. I actually have 2 residents, and I just have a medical student that's helping me screen also. So I'm hoping that I actually sent out an email to ask about how many folks they screened this week. So I don't have the exact number, but it's about 3 days worth at this point.
I think one thing that's good about presenting to an audience of healthcare providers is you really don't have to explain that you have too much to do. We get it. Okay, thank you for a terrific presentation about a really important topic.